Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be going over disorders of sulfur-containing amino acids. So the diseases that I am going to cover in this lecture is Homocystinuria or Homocystinemia, Cystathioninuria, Cystinuria, cystinosis, hereditary sulfite oxidase deficiency. Let's get into the details of these diseases. Homocystinuria, sometimes mentioned as homocysteinemias, these two terminologies are used interchangeably, so you don't need to get confused with the terminologies. Whether it is homocystinuria or homocysteinemias, we are referring to the same disease. It is autosomal recessive disorder which is related to methionine metabolism. The types of homocystinurias can be classified as type 1 homocystinuria, type 2 homocystinuria and type 3 homocystinuria. Now the type 1 homocystinuria is because of defect in a gene that is coding for cystathionin beta synthase enzyme. And note that the cystathionin beta synthase enzyme, it is involved in the transsulfuration pathway of conversion of methionine into cysteine and 𝗏-ketobutyrate, and 𝗏-ketobutyrate later it will be converted into propionyl-CoA. We have seen this in the metabolism of methionine, where I have explained you in my earlier lectures that how the sulfur that is present in the methionine is transferred to cysteine. So there is a transsulfuration pathway where the sulfur of methionine is all the way transferred to cysteine, and in the transsulfuration pathway there is involvement of enzyme cystathionin beta synthase that needs pyridoxal phosphate. So the kind of defect you see in homocystinuria type 1 is the cystathionin beta synthase has decreased its affinity for pyridoxal phosphate. So the mutation will lead to defective enzyme, and that defective enzyme will decrease the affinity towards PLP. That is the common defect you see in cystathionin beta synthase enzyme, leading to homocystinuria type 1. Now the homocystinuria type 2 and type 3 is because of defect in methylation pathway, where a defective methylcobalamin synthesis and abnormality in methylene tetrahydrofolate reductase enzyme activity has been noted, which will cause homocystinuria type 2 and type 3. So type 2 is because of deficiency of methylcobalamin, that's a type of vitamin B12, and type 3 because of defect or abnormality in methylene tetrahydrofolate reductase MTHFR. So here is the pathway that is showing both transsulfuration and methylation reactions, where type 1 homocystinuria and type 2 and 3 homocystinuria can be connected. So as you see, conversion of methionine all the way to cystathionin and cysteine here. So the sulfur present in the methionine will be transferred to cysteine, and that is what is a transsulfuration pathway. Transsulfuration. So in the transsulfuration pathway, there is an enzyme called cystathionin beta synthase, which is involved in the conversion of homocysteine into cystathionin beta synthase. We have seen this in the transsulfuration pathway already, and that needs vitamin B6 as pyridoxal phosphate, where the affinity of an enzyme for pyridoxal phosphate is decreased. That will lead to elevation of homocysteine. That causes type 1 homocystinuria. So at this time, what will happen when homocysteine is building up? Just in case if there is a sufficient vitamin B12 and folate is available in type 1 homocystinuria, so some of this homocysteine will be taken towards the methionine and there will be rise in methionine levels. because the defect is only in the transsulfuration pathway, that cystathionine beta synthase enzyme is defective here. Okay, so this is the defect here. So at that time, so there will be conversion of some of the homocysteine into methionine. Okay, so in homocystinuria type 1, the patient will show elevation of both homocysteine and methionine. That's what I want you to remember. So what I am going to do now is, I am going to block this reaction. So transsulfuration pathway, cystathionine beta synthase enzyme catalyzed reaction is blocked. That leads to elevation of homocysteine, and because homocysteine is elevated, there is another way for homocysteine to go, and that is the methylation pathway, where vitamin B12 and folate can take homocysteine into methionine. That's why there will be rise in the methionine also. So in type 1 homocystinuria, there will be rise in both homocysteine and methionine. Make sure you remember that. This is the point that will differentiate type 1 homocystinuria from type 2 and 3. Make sure you remember this. Okay. Now, what if there is a deficiency of cobalamin? Or what if there is a deficiency in tetrahydrofolate? So what will happen? So the methylation pathway is affected now. That means conversion of homocysteine into methionine will be decreased. So there will be decrease in methionine, but there will be increase in homocysteine. Right? Then you may ask me a question. Okay, since there is a increase in homocysteine, but since transsulfuration pathway is good, because we are not talking about defect in the transsulfuration pathway, we are talking about defect in the methylation pathway now. Why don't homocysteine go down into transsulfuration pathway and become cysteine alpha ketobutyrate, and then it goes into propionyl CoA and like that. So why don't homocysteine run down into cysteine formation? Why homocysteine is building up? To answer that question, that will happen. Homocysteine in fact will go into cystathionine formation, then it will go into cysteine formation. But note that whenever cysteine builds up, whenever there is increase in the cysteine in the cell, this cysteine will have a negative feedback effect on cystathionine beta synthase enzyme. And note that cystathionine beta synthase is a regulated enzyme. So excess cysteines will have a negative effect on the enzyme, and that eventually lead to buildup of homocysteine. That's why in type 2 and type 3 homocystinuria, there will be increase in homocysteine. In fact, there will be either normal or decrease in methionine levels. Remember that. What are the clinical presentations of homocystinemias? Excessive blood clotting is one of the things that is seen here. That's because homocysteine, it's going to interfere with the clotting mechanism, means increases the thrombosis. It's going to decrease the anti-clotting mechanism, like overall promoting clotting process. It can cause endothelial damage, endothelial injury, lipid peroxidation. There are so many effects of homocysteine. That's why homocysteine elevation is an independent risk factor for coronary artery disease or cerebral vascular events like myocardial infarction or stroke. That's why elevation of homocysteine is a risk factor leading to excessive blood clotting and other consequences. And also, elevated homocysteine may promote accelerated atherogenesis by increasing the reactive molecule formation, lipid peroxidation, endothelial damage, leading to accumulation of LDLs in the subintimal space. Patients with homocystinemia will show morphonoid signs related to skeletal system. Like Marfan syndrome will show arachnodactyly, disproportionate body, then pectus excavatum, pectus carinatum, unusual stretch marks, high arched palate. These are some of the skeletal manifestations of homocystinemias, which are very similar to Marfan syndrome clinical signs and symptoms, especially related with skeletal system. That's why here I have mentioned it as morphonoid signs. Patients with homocystinemia will show osteoporosis. Patients with homocystinemia will show mental retardation. Damage to the neuronal network of the retina may lead to blindness. Lens dislocation is seen, which is in infero-medial direction or downward and medial direction. Deep vein thrombosis and grand mal epilepsy. The grand mal epilepsy is because of decrease in adenosine in homocystinemia, and adenosine is an inhibitory neurotransmitter in the central nervous system. Decrease in the adenosine will lead to increase in the excitatory effect. That's why it can lead to grand mal epilepsy. So these are some of the signs of homocystinemia, clinical presentation of homocystinemia patients. Some of these signs are similar to Marfan syndrome, especially with the skeletal manifestation and lens dislocation. So lens dislocation will differentiate also between homocystinemia and Marfan syndrome. That means in homocystinemia, lens dislocation is in downward and medial direction, whereas in Marfan syndrome it is upward and lateral direction, superotemporal. Alright, so make sure you remember the clinical presentation and also how to differentiate Marfan syndrome from homocystinemia. Homocystinemia, additional signs that you see which you don't see in Marfan syndrome, they are blood clotting, you don't see in Marfan syndrome generally, accelerated atherogenesis, osteoporosis, mental retardation, deep vein thrombosis, grand mal epilepsy. Generally you don't see them in Marfan syndrome, but they are seen in homocystinemia along with lens dislocation and Marfanoid signs. Now, laboratory investigation is urine screening for sulfur-containing amino acid. The test that is done is cyanide nitroprusside test. GU3 test can also be done, although GU3 test is used in screening for phenylketonuria, but GU3 test can be used for screening of not only phenylketonuria but also for leucine and methionine. Measurement of cystathionine beta synthase activity in cultured fibroblasts provides a definitive support for the diagnosis. Methionine challenge test is done if a deficiency is suspected in transsulfuration pathway. That means whenever methionine is supplemented, the increase in cysteine cannot be seen because transsulfuration pathway is affected. Blood levels of homocysteine determined. In the presence of homocystinemia, test for deficiency in folic acid, vitamin B12, pyridoxine is also performed. Why? Because for transsulfuration pathway, pyridoxine is needed. For methylation pathway, folic acid and cobalamin is needed. So, measurement of these vitamins helps in the diagnosis, because if there is a pyridoxine deficiency, it indicates transsulfuration pathway be defected. If it is a cobalamin deficiency or folate deficiency, it is the methylation pathway that is decreased. Now, treatment is pyridoxine, which is a drug of choice for this condition, because commonly it is homocystinemia is because of genetically because of cystathionine beta synthase enzyme being defective, where affinity for pyridoxal phosphate, pyridoxine derivative, is decreased. So, giving more pyridoxine 100 to 500 milligram per day will improve the enzyme activity. Measurement of measuring homocysteine levels can be used in monitoring the effectiveness of the treatment. If the pyridoxine alone is not effective, addition of folic acid and vitamin B12 can be added to the regimen. If patients are pyridoxine insensitive, low methionine diet is initiated at the diagnosis along with the betaine supplementation, because betaine supplementation helps in the conversion of homocysteine into methionine, because betaine can donate methyl group in this conversion process. Now, the secondary stroke prevention because of the thromboembolic episodes can be prevented by prescribing aspirin, clopidogrel or aspirin dipyridamole, so that platelet aggregation and clot formation can be decreased. Now, let us move on to see cystathionuria. Cystathionuria is because of deficiency in enzyme cystathionase. cystathionase enzyme, it is involved in the breakdown of cystathionine into cysteine. So this cystathionine levels will be elevated in the blood and appearing in the urine, leading to cystathionuria. It's a relatively benign condition and patients largely remain asymptomatic. Coming to cystinuria. Cystinuria is because of the autosomal recessive defect in the absorption of intestinal and reabsorption in the renal tubular cells for cysteine, and this is accompanied by other dibasic amino acids like ornithine, arginine and lysine. Basically, it's a dual organ effect where intestines are decreasing the absorption of cysteine, ornithine, arginine, lysine from the food, and renal tubular cells are decreasing their reabsorption of these molecules from the renal tubular. Kidney is decreasing the reabsorption of these molecules from the renal tubular cells. So the only phenotypic manifestation that you see in cystinuria is cystine urolithiasis, that is cystine stones. And signs includes renal colic, chronic urinary tract infection, positive family history, passage of stones or gravel in the urine, hematuria and painful urination. And the cystine stones in the urine, when observed under microscope, will show the hexagonal crystals. Remember that. Hexagonal crystals in the urine. Now the foundation of cystine stone prevention is to provide adequate hydration and urinary alkalinization so that precipitation do not happen. Coming to cystinosis and hereditary sulfite oxidase deficiency. Cystinosis is a deposition of cystine crystals in various tissues and organs. The crystals are deposited in lysosome. Renal functions are seriously affected in this disease, and many patients they die because of renal failure in early age. Hereditary sulfite oxidase deficiency, it may occur alone or it may occur along with xanthine oxidase deficiency. Both hereditary sulfite oxidase and xanthine oxidase enzymes, they both contain molybdenum. And patients exhibit mental retardation, motor seizures, cerebral atrophy and lens dislocation in this disorder. Dietary deficiency of molybdenum can cause deficient activity of both xanthine oxidase and sulfide oxidase. So that is one of the cause for hereditary sulfite oxidase deficiency. So these are all disorders of sulfur containing amino acids. Thank you.